Welcome back to the Deep Dive. Today we are tackling something pretty intense. We're diving into the world of cancer treatment specifically, chemotherapy, and some of the more targeted hormonal strategies.
Yeah, it's a complex area.
Definitely. Our goal here is to take what are often very dense, very technical medical notes and sort of translate them, make them understandable. We want to get under the hood of this balancing act clinicians face.
It really is a balancing act. You're dealing with powerful drugs designed to kill cells, cytotoxic agents. That's their job.
Right.
And the sources we're looking at today, they're basically the playbooks, detailed protocols on how these drugs work, the mechanisms, the very real risks, and how doctors and nurses manage them minute by minute.
And the core challenge, as you said, is achieving that complete kill of the cancer cells while somehow managing the extreme toxicity these drugs bring to the patient's whole system.
Exactly. It's about eradication versus toxicity. That's the tightrope.
So the mission today is understanding the what, the how, and maybe most importantly, the so what, the consequences. And we have to start with that fundamental truth. Chemotherapy is a toxin.
It is. And because cancer cells are incredibly adaptable, they can develop resistance really quickly.
Which means you can't usually just use one drug.
Almost never. The standard approach right out of the gate is combination chemotherapy. You'll often see patients receiving multiple bags of different chemo drugs at the same time.
Multiple bags simultaneously.
Yeah. It's an aggressive, proactive strategy. The idea is to hit the cancer cells from different angles, using drugs with different mechanisms of action all at once.
So you're attacking its DNA replication and maybe its cell division process at the same time.
Precisely. You don't give it a chance to figure out one line of attack before you hit it with another. If you use just one drug, you risk selecting for resistant cells.
And those resistant cells are the ones that survive and cause problems later.
Exactly. That's how you get into what we call a refractory situation, where the cancer stops responding. Much, much harder to treat then.
Okay, let's really unpack this high-stakes game. Challenge number one, you said, is inherent. Toxicity. It's not a side effect you try to avoid. It's expected.
It's absolutely expected. You have to go in knowing there will be systemic toxicity. It's unavoidable.
Why is it so unavoidable?
Well, think about what chemotherapy targets. It targets rapidly dividing cells. Cancer cells divide rapidly. That's the target. But so do lots of healthy cells in our body.
Like where?
Your bone marrow, constantly making blood cells, the lining of your mouth, and your entire digestive tract. Hair follicles. These are all high-growth areas.
So they get caught in the crossfire.
Exactly. That collateral damage to healthy, fast-growing tissues, that's where most of the really difficult side effects come from. That's the price of admission, unfortunately.
And you accept that toxicity because the second goal is so critical. Complete cell death. You need to eradicate the tumor.
You have to aim for eradication. If the treatment doesn't get a good response, if it doesn't kill enough cells, that's when we start talking about the cancer being refractory.
And refractory is basically bad news.
It means the treatment isn't working well, and the prognosis becomes much more challenging. And it's often tied directly to the third big challenge, drug resistance.
Ah, resistance. The nightmare scenario.
It really is. Cancer cells are masters of survival. If even a few cells figure out a way to survive the drug, maybe they learn to pump it out, or they find a way around the biochemical pathway the drug targets.
They multiply.
They multiply. And the cancer that comes back is now armed against that drug and often more aggressive. It's a constant threat we're fighting against from day one.
Okay, so we've got toxicity, the need for a total kill, the threat of resistance. What was the fourth challenge mentioned in the notes? Something more logistical.
Right, that's limited drug access. This isn't about cost or availability, usually. It's about the tumor itself. Some solid tumors, especially larger ones, can have really poor blood supply deep inside. They're not well vascularized.
Okay.
So even if you flood the patient system with chemotherapy, the drug might not physically be able to penetrate deep into the tumor core in a high enough concentration to kill all the cells there.
So parts of the tumor are almost hiding from the drug.
In a way, yes. It makes it much harder to achieve that complete kill no matter how high a dose you give systemically.
So facing these huge challenges, toxicity, kill rate resistance, access, how do clinicians fight back? We know it's not just one drug.
The strategy has to be multi-layered. It's about integration and timing. First, chemotherapy is often part of a bigger plan.
You mean combined with surgery or radiation?
Exactly. Surgery to physically remove the bulk of the tumor, radiation to deliver a very focused, high-dose kill to a specific area. Chemo handles the systemic part, the cells that might have spread.
But focusing just on the chemo drugs themselves, what are the key strategies?
Two big ones stand out in the protocols. First is intermittent chemotherapy.
Controlling the timing, you mean, like cycles.
Precisely. Chemo is almost always given in cycles. A round of treatment, then a rest period. Treatment, rest.
Why the rest period?
It's absolutely crucial. It allows the patient's healthy tissues, especially the bone marrow, time to recover. Remember that collateral damage? The rest period lets the body rebuild its healthy cell populations.
If you just kept giving the chemo.
You'd overwhelm the body's ability to recover. The toxicity would become fatal faster than the cancer. So timing is everything. Letting the good cells bounce back while hoping the cancer cells don't recover as quickly.
Okay, that makes sense. And the second key strategy?
Combination chemotherapy. We touched on it, but this is really the cornerstone of most modern treatment regimens.
Using several drugs at once.
Yes, but not just any drugs. You carefully select drugs that work in different ways, different mechanisms of action, and ideally have different main toxicities so they don't all hammer the same organ system too hard.
So maybe one drug hits DNA, another stops cell division.
Right, and maybe one is tough on the kidneys, while the other mainly affects the nerves. You spread the toxic load. This multi-pronged attack maximizes the chance of killing all the different populations of cancer cells and, critically, makes it much harder for resistance to develop.
It's like attacking a fortress from multiple directions simultaneously.
That's a good analogy. And because these combination therapies are often so potent, we also have to factor in other things like wound healing.
Ah, right. Chemo delays healing.
Significantly. So if a patient is having chemo before surgery or needs surgery soon after, that delayed healing becomes a major clinical consideration. You have to plan for it.
Let's dive into that toxicity, the expected toll. This is where the day-to-day, moment-to-moment patient management really happens. The biggest, most immediate concern, often the one that limits how much chemo can be given, is bone marrow suppression.
This is the absolute core trade-off. The bone marrow is one of the body's fastest-growing factories, pumping out red cells, white cells, platelets. Chemo hits it hard.
And the consequences are severe.
They are. It's a triple threat, really. First, suppressing white blood cell production, especially neutrophils, cripples the immune system. The patient becomes highly vulnerable to infections. Even a slight fever can signal a life-threatening emergency requiring immediate antibiotics.
Okay, risk of infection. What else?
Second, suppressing red blood cell production leads to anemia. This causes profound fatigue, weakness, shortness of breath. It really impacts quality of life.
And third?
Platelets. Suppressing platelet production interferes with blood clotting, so the patient is at high risk for bruising and potentially serious bleeding. They become incredibly fragile.
Vulnerable on all fronts. Now, the notes mention something really counterintuitive. A falling blood count, the CBC, can actually be seen as a good sign. That seems terrifying.
It is terrifying, but it's also true in a way. A significant drop in the CBC, especially the white cells, tells us the chemotherapy is potent, it's working, it's successfully targeting rapidly dividing cells.
Because the bone marrow cells are dividing rapidly.
Exactly. So if the chemo is hitting the bone marrow hard, it's very likely hitting the rapidly dividing cancer cells hard too.
But that drop is also incredibly dangerous.
Extremely dangerous. That lowest point, called the nadir, is when the patient is most vulnerable. So while the drop shows the drug is active, it demands hyper-vigilant monitoring. We're not just looking at the number, we're watching the trend, anticipating that nadir, and intervening quickly to prevent disaster.
Wow. Okay, let's shift to another area full of rapidly dividing cells, the digestive tract. The notes mention injury here causing things like mouth sores, diarrhea, constipation.
Yes, the entire GI tract lining turns over very quickly, so it's very sensitive to chemo. Stomatitis or painful mouth sores is common. Diarrhea and constipation can also occur.
The note specifically flags severe diarrhea as a potential sign of serious injury.
Absolutely. Severe persistent diarrhea isn't just uncomfortable, it can indicate significant damage to the mucosal lining of the gut. That damaged lining can become a gateway for bacteria from the gut to enter the bloodstream, leading to systemic infection or sepsis.
So what's the protocol if a patient reports really bad diarrhea?
It often requires stopping the specific chemo drug immediately and notifying the doctor. You can't just treat it like regular diarrhea. It's a sign the toxicity threshold for the gut has been breached.
Okay, this leads us straight into probably the most universally recognized side effect: nausea and vomiting. The notes stress that management has to be automatic, preventative.
Yes, the gold standard is giving anti-nausea medication like ondansetron before the chemo starts, usually 30 minutes to an hour prior.
Why is that timing so critical? Why not wait until the patient feels sick?
Because of how nausea is triggered, chemotherapy stimulates a specific area in the brainstem called the chemoreceptor trigger zone, or CTZ. Once that zone is activated and the vomiting reflex kicks in, it's incredibly difficult to stop.
So you're trying to block the signal before it even starts the cascade.
Exactly. If you wait until they feel nausea, you've already lost half the battle. Prevention is key. Block the receptors before the chemo has a chance to stimulate them.
Beyond the drugs, what about just the practicalities of eating? The notes mention a metallic taste.
Very common. Many patients report a persistent metallic or unpleasant taste that makes food unappalling. It makes maintaining nutrition and hydration really difficult.
Any tips for managing that?
Bland foods often work best. Things like plain toast, crackers, simple broths, maybe rice. Avoiding strong smells or flavors can help. The goal is just to get calories and, crucially, fluids in.
Fluids. That brings us to another really vital point from the notes. Elimination. It sounds basic, but it's critical for safety, right? The dead cells and the drugs have to get out of the body.
Absolutely critical. They exit primarily through urine and feces. If those routes are blocked or slow, the toxins hang around longer, increasing the damage.
So hydration is non-negotiable.
Non-negotiable. We push fluids aggressively. We monitor input and output, often hourly, making sure what goes in is coming out. We watch kidney function tests like BUN and creatinine like a hawk.
Because the kidneys are filtering out all these toxins.
They're working overtime. We need them functioning well. And similarly, for the bowels, we need to prevent constipation. If the patient isn't having regular bowel movements, we need to intervene quickly with things like Miralax or Senokot.
So keep everything flowing out.
Keep it moving, dilute the toxins with fluids, flush them out via the kidneys, and eliminate waste promptly through the bowels. It minimizes the duration of exposure for healthy tissues.
Got it. Finally, what other major toxicities are generally expected?
Well, alopecia hair loss is very common with many regimens, though usually reversible. Reproductive injury is a significant concern, potentially causing infertility.
Anything else?
Hyperuricemia, high uric acid levels, which ties into tumor lysis syndrome, something we need to discuss. And then there's the really sobering long-term risk. Secondary disease.
Secondary disease, you mean another cancer?
Often, yes. Years after successful chemotherapy or radiation, particularly those treatments that directly damage DNA, there's an increased risk of developing a second, unrelated cancer, frequently leukemia. It's a devastating potential long-term consequence of the cure itself.
You mentioned tumor lysis syndrome, TLS. The notes describe this as a dangerous consequence of the chemo working too well too fast. Explain that.
It's a metabolic emergency. Imagine you have a large tumor or a cancer like leukemia with a very high cell count. When the chemo hits it effectively, vast numbers of cancer cells die and rupture almost simultaneously.
Your lights break open.
Exactly. And they dump all their intracellular contents into the bloodstream, potassium, phosphate, and the breakdown products of DNA and RNA, which are purines.
Purines, like from diet.
Related, but here it's from the cell's own nucleic acids breaking down. Purines get metabolized into uric acid, so suddenly the bloodstream is flooded with potassium, phosphate, and a massive amount of uric acid.
And what does that flood do? What's the immediate danger?
The biggest immediate threat is to the kidneys. The sheer load of uric acid can crystallize in the renal tubules, like sludge, causing acute kidney injury, potentially leading to complete renal failure very quickly.
Kidney failure from too much cell kill.
Yes. And the high potassium, the hyperkalemia, can cause life-threatening cardiac arrhythmias. The high phosphate can cause low calcium, leading to muscle cramps and seizures. It's a systemic catastrophe triggered by effective treatment.
So knowing this risk exists, especially with certain cancers, what's the absolute #1 priority for managing the patient?
Hydration. Aggressive, relentless hydration. Forder fluids. Encouraging oral intake. The goal is to dilute everything that's being dumped into the blood and, crucially, to keep urine flowing rapidly through the kidneys to flush out the uric acid before it can crystallize and cause damage.
How aggressive are we talking?
We're talking strict IO monitoring, aiming for equal or positive fluid balance. Patients might need to be woken up hourly to drink and urinate. We need high urine output.
But wait, you just said patients often have terrible nausea and vomiting and that metallic taste. How do you get them to drink hourly?
That's the crux of the challenge. You have to be incredibly aggressive with the anti-nausea medications precisely so you can hydrate them effectively to prevent TLS. Managing the nausea isn't just for comfort, it's literally a kidney-saving, life-saving intervention in this context.
It's all interconnected.
Yeah.
What if the hydration and standard preventative drugs like allopurinol which reduces uric acid production, aren't enough.
If TLS is severe, allopurinol might not cut it because it only stops new uric acid formation. It doesn't get rid of what's already there. In that case, we escalate to a drug called rasburicase.
Rasburicase.
It's an enzyme that directly breaks down existing uric acid very rapidly. It's much more potent, but also carries its own risks and is much more expensive. It's reserved for severe established TLS to try and rescue kidney function.
It really highlights the intensity of monitoring required.
Yeah.
Now let's switch gears to the safety of just handling these drugs. The protocols for staff sound incredibly strict.
They have to be. These are potent cytotoxic chemicals. They need to be handled essentially like hazardous materials.
What does that involve?
It starts before administration. Every chemo dose requires a 2-nurse check. 2 RNs independently verify the drug, the dose, the patient, the route, the rate. 0 room for error.
And the PPE, the protective gear.
It's layered. Double gloves are standard. A special chemotherapy gown, usually impermeable, that covers the cuff of the inner glove. Then a second pair of gloves goes over the gown's cuff.
Why the double layer in covering the cuff?
To prevent any possible skin contact. If there's a spill, you don't want the drug running down inside the sleeve or glove onto the skin. It provides a sealed barrier.
And the risk doesn't end when the infusion is done.
Not at all. The drugs and their metabolites are excreted in urine, feces, sweat, vomit for usually 48 hours or more. So all body fluids and anything contaminated by them, like bed linens or diapers, must be treated as hazardous waste. Specific disposal procedures are required to protect everyone's staff, other patients, housekeeping, the environment.
Okay. What about specialized administration routes? The notes mention intrathecal chemo directly into the spinal fluid. There's a strict rule about who does what.
Absolutely vital distinction here. Giving chemo intrathecally into the cerebrospinal fluid bypasses the blood-brain barrier to treat or prevent cancer in the central nervous system. The actual injection, the lumbar puncture, and administration of the drug must be performed by a physician.
So nurses don't inject intrathecal chemo?
No, the nurse's role is critical, preparing the patient, assisting with positioning, monitoring vital signs, managing post-procedure care, but the injection itself is a physician-only procedure due to the high risks involved.
Got it. And just to reiterate, one last point on general safety: chemo significantly delays wound healing.
Yes, always keep that in mind, especially around surgeries.
All right, let's get into the specifics of the drugs themselves. We group them by how they work, their mechanism of action, or MOA. First up, the DNA targeting agents. Alkylating agents and platinum compounds. These sound like heavy hitters.
They are. The alkylating agents are some of the oldest chemo drugs. Their main job is to directly damage DNA by adding an alkyl group to it. This messes up the DNA structure, causing breaks and cross-links, so the cell can't replicate its DNA or make proteins properly, leading to cell death.
Broad spectrum, the notes say.
Very broad spectrum, yes. They hit any rapidly dividing cell, which is why they're effective, but also why they cause significant toxicity, especially to the bone marrow. And resistance is a common problem.
And a big warning right off the bat. They're vesicant. What does that mean for giving the drug?
Vesicant means it causes severe tissue damage, blistering, and necrosis if it leaks out of the vein during infusion. This is called extravasation.
So if the IV isn't perfectly in the vein?
It can cause devastating injury, sometimes requiring surgery. That's why these drugs are often preferably given through a central line, like a PICC or port, which sits in a large vein where blood flow is high, reducing the risk. If given peripherally, the IV site needs constant watching.
Okay, let's look at a specific one. Cyclophosphamide, brand name Cytoxan, a nitrogen mustard.
Yes, it's a very widely used alkylating agent. Good for lymphomas like Hodgkin's and non-Hodgkin's, multiple myeloma, also some solid tumors like breast and ovarian cancer.
What's its main dose-limiting toxicity?
Like many alkylators, it's bone marrow suppression. That's often what limits how much we can give. But cyclophosphamide has a very specific major side effect you have to associate with it: acute hemorrhagic cystitis.
Hemorrhagic cystitis, bleeding from the bladder. So cyclophosphamide equals bladder toxicity. Why the bladder?
It's not the drug itself, but one of its metabolites. As the body breaks down cyclophosphamide, it produces a substance called acrolein, which concentrates in the urine and is incredibly irritating to the bladder lining,
Causing inflammation and bleeding.
severe inflammation and bleeding. It can be incredibly painful and dangerous. So managing this risk is paramount.
How do you protect the bladder?
2 key things. First, aggressive hydration to keep the urine dilute and flush the bladder frequently. Second, we often co-administer a protective drug called Mesna. Yes, mesna circulates in the blood and concentrates in the bladder, where it binds directly to the toxic acrolein metabolite, neutralizing it so it can be safely excreted without damaging the bladder lining.
So hydration and mesna are key. Any other administration details?
Patients need to urinate very frequently, even needing to be woken up at night to void to keep flushing the bladder. Any pelvic pain could be a warning sign. It can be given orally, ideally with food to reduce stomach upset or IV, and importantly, it doesn't cross the blood-brain barrier.
Okay, moving to another type of alkylating agent, the nitrosoureas, like carmustine,
Carmustine is notable because it does cross the blood-brain barrier quite well.
which makes it useful for.
Brain tumors. It's one of the mainstays for treating primary brain cancers like glioblastoma.
What's unique about its toxicity?
Its main dose-limiting toxicity is delayed bone marrow suppression. This is really important. Unlike many chemo drugs where the blood counts drop within a week or two, with carmustine, the nadir, the lowest point, might not occur until 4 to 6 weeks after the infusion.
Wow, so the risk period is much longer.
Much longer. You need extended monitoring. Other potential toxicities include liver and kidney damage, and sometimes pulmonary fibrosis, scarring in the lungs.
Okay, let's switch to the platinum compounds, also DNA targeters, but work slightly differently.
Right. Drugs like cisplatin, carboplatin, they also mess up DNA, but they do it by forming strong chemical cross-links, both within a single DNA strand and between the two strands of the double helix. This physically prevents the DNA from unwinding and replicating. They are cell cycle phase nonspecific, meaning they can kill cells at any stage.
Cisplatin, brand name Platinol. What's it used for?
It's particularly important in treating metastatic testicular cancer, a real success story there, and also ovarian and advanced bladder cancers. Not quite as broad spectrum as cyclophosphamide.
And if cyclophosphamide is the bladder, cisplatin is definitely the kidneys. Dose-limiting kidney damage. Why?
Cisplatin is heavily reliant on the kidneys for excretion, and it's directly toxic to the renal tubules. High concentrations can cause severe, sometimes permanent kidney damage.
So kidney protection is priority one.
Again, hydration. Hydration, hydration. Often massive amounts of IV fluids, sometimes liters given before, during, and after the cisplatin infusion. The goal is purely dilution, keep the concentration of the drug low as it passes through the sensitive kidney tubules. We monitor kidney function tests, BUN, creatinine, and urine output religiously, often hourly. Sometimes diuretics like mannitol are used too, to force urine production.
Makes sense. What else does cisplatin do? It sounds rough.
It is rough. It's one of the most highly emetogenic chemo drugs we have, causes severe nausea and vomiting. Aggressive anti-nausea treatment is essential. It also commonly causes peripheral neuropathy, tingling, numbness, pain in hands and feet, which can be long-lasting. Ototoxicity is another big one.
Ototoxicity. Hearing damage.
Yes, damage to the auditory nerve or inner ear structures. It can cause tinnitus, ringing in the ears, high-frequency hearing loss, and sometimes balance problems. And like most of these, it also causes bone marrow suppression. The risks, especially kidney damage and neuropathy, are very dose-dependent.
Okay, shifting gears now to antimetabolites. These are more sneaky, right? They interfere with the building blocks of DNA and RNA, and they're specific to the S phase of the cell cycle.
Exactly. The S phase is when the cell synthesizes or copies its DNA in preparation for dividing. Antimetabolites work by mimicking the normal building blocks, metabolites that cells use to make DNA and RNA, or by blocking the enzymes needed for that synthesis. By disrupting this process, they halt replication and kill the cell, but only when it's actively trying to make DNA in the S phase.
First one, methotrexate, a folic acid analog.
Right. Methotrexate looks a lot like folic acid. It tricks the enzyme dihydrofolate reductase, DHFR, into binding it instead of folic acid. This enzyme is crucial for activating folic acid into a form needed to make thymidine and purine's essential DNA components. So methotrexate effectively starves the cell of these building blocks.
Where do we see methotrexate used?
It's used in high doses for certain cancers, like some leukemias and lymphomas. Interestingly, it's also used in much lower doses for autoimmune diseases like rheumatoid arthritis and Crohn's disease. And importantly for cancer, it does cross the blood-brain barrier, so it can be used for CNS cancers or prophylaxis.
Toxicities.
Bone marrow suppression is major. Pulmonary fibrosis, like we saw with carmustine. And because it hits rapidly dividing cells, it causes severe mucositis, painful sores in the mouth and throughout the GI tract. But the big, unique challenge with high-dose methotrexate is kidney toxicity, but for a different reason than cisplatin.
How is it different?
Methotrexate itself isn't directly toxic to kidney cells in the same way cisplatin is. The problem is solubility. Methotrexate can precipitate or crystallize in the acidic environment of the renal tubules, physically blocking them and causing kidney failure.
So you need to change the urine's pH.
Exactly. The protocol is intense. Before giving high-dose methotrexate, the patient must be aggressively hydrated, and their urine must be alkalinized, made basic, usually by giving IV sodium bicarbonate. We constantly check the urine pH with test strips. The infusion cannot start until the urine pH is above a certain safe threshold, often 7.0 or higher.
Wow. And getting the drug out afterwards is also complex.
Yes. Because high doses are so toxic, patients need what's called leucovorin rescue. Leucovorin is a form of activated folic acid that bypasses the blockade caused by methotrexate, allowing healthy cells to recover.
So it's an antidote.
It's a rescue agent, yes, but timing is critical. Given too early or wrongly, it can interfere with the chemo's effect, or paradoxically enhance toxicity in some situations. We administer leucovorin on a strict schedule after the methotrexate, and we monitor the methotrexate levels in the blood. The patient cannot be safely discharged until their blood level drops below a very specific, very low threshold, often 0.01 micromolar.
And a crucial warning for pregnancy.
Absolutely. Methotrexate is highly teratogenic. It can cause severe fetal malformation or death. It's actually used sometimes for medical termination of ectopic pregnancies. Strict contraception is required during and for some time after treatment. Patients on lower doses for RA often take folic acid supplements to mitigate some side effects, but that's different from the high-dose rescue.
Okay, next antimetabolite. Fluorosil or 5-FU, a pyrimidine analog.
Right. Pyrimidines are one class of DNA bases, thymine, cytosine. 5-FU looks like uracil and thymine. Its main action is inhibiting a key enzyme called thymidylate synthetase.
Who does what?
That enzyme is essential for making thymidine, one of the T bases in DNA. So 5-FU deprives the cell of thymidine, halting DNA synthesis. It's mainly used for solid tumors like colon, breast, stomach, pancreatic cancer, often given as a continuous IV infusion over days.
Main toxicities.
Similar themes. Bone marrow suppression and GI toxicity, particularly mucositis and diarrhea. And again, that diarrhea can be a major warning sign.
The same rule applies as with some other drugs. Severe diarrhea means stop.
Yes. With 5-FU, severe diarrhea often signals significant damage to the GI mucosa. It requires immediate cessation of the infusion and contacting the provider. It can become life-threatening if not managed.
Is there an antidote if things get really bad?
Yes, there is. A drug called uridine triacetate can be given to counteract severe 5-FU toxicity. It helps normal cells bypass the drug's effects.
Any other notable side effects?
Hand-foot syndrome is quite characteristic of 5-FU infusions. It causes redness, swelling, tingling, and sometimes blistering on the palms of the hands and soles of the feet.
Okay. One more antimetabolite. Mercaptopurine, a purine analog.
Right. This one mimics the purine bases, adenine, guanine. Mercaptopurine gets incorporated into DNA and RNA, disrupting their structure and function, and it also interferes with purine synthesis pathways.
What's his main use?
Its primary role is in maintenance therapy for acute lymphocytic leukemia, AL, particularly in children, to help keep the leukemia in remission after initial treatment.
Dose-limiting toxicity.
Bone marrow suppression, as expected. It also carries a risk of liver toxicity, hepatotoxicity. Usually it's mild, just elevated liver enzymes, ALT, AST, bilirubin, that we monitor.
But it can be serious.
Rarely, it can progress to severe, even fatal liver damage. So regular liver function monitoring is essential. And like methotrexate, it's not used during pregnancy. Hashtag tag tag 4.3 anti-tumor antibiotics.
All right, moving on to a different class, anti-tumor antibiotics. These aren't like penicillin, right? They're cytotoxic drugs originally derived from microbes.
Exactly. They're not used for infections. They're potent cancer-killing agents isolated from Streptomyces bacteria mostly. They generally work by interacting directly with DNA.
And the most famous, or maybe infamous example is doxorubicin. Nicknamed the Red Devil. Why that name?
Two reasons. Mainly, first, the drug itself is bright red, and
Yeah.
second, it's associated with some significant toxicities. It belongs to the anthracycline class.
How does it work?
It has a couple of mechanisms. It intercalates into DNA, meaning it physically slips between the base pairs of the DNA helix, disrupting transcription and replication. It also inhibits an enzyme called topoisomerase II, which is needed to repair DNA breaks that occur during replication. So it jams up DNA processes in multiple ways. It's very broad spectrum, used for many cancers.
You mentioned significant toxicities. What should patients expect?
Well, the most immediate visible thing is that it turns urine and sweat a reddish pink color for a day or two after infusion. This is expected, harmless, but patients need to be warned so they don't panic.
Good to know. Any handling precautions?
Yes, it's photosensitive, meaning light degrades the drug. So the IV bag and tubing must be covered, usually with a brown or opaque bag, during the infusion.
And the administration risk, is it a vesicant?
Oh, absolutely. Doxorubicin is one of the most notorious vesicants. Extravasation leaking outside the vein causes massive tissue necrosis, potentially requiring skin grafts or even amputation in extreme cases.
So how much to be given?
It absolutely must be given through a secure, free-flowing 5E line, preferably a central venous catheter like a PICC line or port. If given peripherally, it requires extreme caution. The standard nursing protocol is to check for blood return from the IV catheter every 5 minutes or even more frequently during the infusion.
Check for blood return.
Yes, gently pulling back on the syringe connected to the IV line to ensure blood flows back easily. This confirms the catheter tip is still correctly positioned within the vein. If there's any doubt, any swelling, pain, or lack of blood return, the infusion must be stopped immediately.
Okay, that's the immediate risk. But doxorubicin is infamous for a major long-term toxicity, isn't it?
Yes. The biggest concern with doxorubicin is cardiotoxicity, damage to the heart muscle.
How does that manifest?
It can cause two types of problems. Acute effects can happen during or soon after infusion, things like temporary ECG changes or arrhythmias. These are usually reversible. The much bigger worry is the delayed effect, a cumulative dose-related cardiomyopathy.
Meaning the more drug you get over your lifetime, the higher the risk.
Exactly. The heart muscle gets progressively weaker, leading to symptoms of congestive heart failure, which can occur months or even years after treatment finishes and is often irreversible.
How is this managed? Is there a limit?
Yes, there's a generally accepted maximum lifetime cumulative dose for doxorubicin, typically around 550 milligemeter ornithine. Oncologists track this meticulously for each patient.
And how do they monitor heart function during treatment?
Before starting and periodically during treatment, patients need heart function tests, most commonly an echocardiogram, echo, or a MUGA scan, to measure their left ventricular ejection fraction, LVEF.
Ejection fraction, that's a measure of pumping strength.
Yes, it's the percentage of blood pumped out of the left ventricle with each heartbeat. A normal EF is typically above 55%. If a patient's EF drops significantly during treatment, say below 50%, or drops by more than 10% from baseline,
What happens?
the nurse absolutely must hold the dose and contact the physician immediately. Continuing doxorubicin with the falling EF is very risky. It often requires a difficult discussion about risks versus benefits, and potentially stopping the drug or switching to a different regimen. An addendum order specifically acknowledging the low EF and authorizing proceeding is usually required. Hashtag 4.4. Mitotic inhibitors, M-phase specific, and miscellaneous.
Okay, next category. Mitotic inhibitors. These target cells specifically during mitosis, the M phase, when they're actively dividing. First example, vincristine from the vinca alkaloid family.
Right. Vincristine works by binding to tubulin, the protein that makes up microtubules. Microtubules form the mitotic spindle, the structure that pulls chromosomes apart during cell division. Vincristine prevents the spindle from forming correctly, arresting the cell in metaphase mid-division.
Is used alone?
Often given in combination regimens, for example, in treating leukemias, lymphomas, and some solid tumors.
What's its key toxicity? Is it bone marrow?
Interestingly, no. Vincristine is relatively bone marrow sparing, which makes it a valuable partner for drugs that do heavily suppress the marrow. Its major dose-limiting toxicity is peripheral neuropathy.
Nerve damage again, similar to cisplatin.
Similar in type, yes, damage to peripheral nerves. It can affect both sensory nerves, causing numbness, tingling, pain, and motor nerves, causing weakness, foot drop, loss of reflexes. Constipation is also a very common and sometimes severe side effect due to effects on autonomic nerves in the gut.
So monitoring reflexes and watching for constipation are key.
Absolutely. Regular neurological checks, assessing deep tendon reflexes, DTRs, asking about numbness or weakness, and proactive bowel management with laxatives like Miralax or Senokot is essential from day one. Patients are at high risk for falls due to neuropathy.
Is it a vesicant like doxorubicin?
Yes. Vincristine is also a vesicant and requires careful ivosivir administration, preferably via central line.
What about hair loss?
Vincristine itself actually causes minimal hair loss, maybe in about 20% of patients. If someone on a vincristine-containing regimen loses their hair significantly, it's almost always due to the other drugs in the combination.
Okay, next, mitotic inhibitor. Paclitaxel, brand name Taxol, from the taxane class. How does it work?
Paclitaxel also targets microtubules, but in the opposite way to vincristine. Instead of preventing them from forming, paclitaxel stabilizes them too much, preventing them from breaking down as needed during cell division. It essentially freezes the cell's internal skeleton, also causing mitotic arrest, primarily in late G2 and M phases.
What's the major immediate concern with paclitaxel?
Severe hypersensitivity reactions. Allergic type reactions can occur, especially during the first or second infusion. Symptoms can range from flushing and rash to shortness of breath, low blood pressure, even anaphylaxis.
How is that managed?
Premedication is standard. Patients typically receive corticosteroids like dexamethasone, antihistamines like Benadryl, and an H2 blocker like famotidine before each infusion to minimize the risk. If a reaction still occurs, the infusion is stopped immediately, the symptoms are treated, and then, if appropriate, the infusion might be restarted at a much slower rate once the patient is stable.
What are the other risks with paclitaxel?
It also causes significant bone marrow suppression and peripheral neuropathy, similar to vincristine, but often cumulative. It can also cause cardiac problems, including bradycardia, slow heart rate, and rarely heart block or even fatal myocardial infarction. So it's generally avoided in patients with significant pre-existing heart conditions.
Okay, one last cytotoxic agent in a sort of miscellaneous category, asparaginase, brand name Elspar. This one sounds different.
It is very different. Asparaginase is an enzyme. Its mechanism is unique. It breaks down the amino acid asparagine that's circulating in the blood.
How does that kill cancer cells?
Most normal cells can synthesize their own asparagine if they need it. However, certain types of cancer cells, particularly acute lymphoblastic leukemia, ALL, lymphoblasts, lack the enzyme to make their own asparagine. They rely entirely on getting it from the bloodstream.
So asparaginase starves them specifically.
Exactly. By destroying the circulating asparagine, asparaginase selectively deprives these leukemic cells of an essential nutrient, leading to their death. It acts primarily in the G1 phase of the cell cycle.
What's remarkable about its side effect profile?
It's almost the mirror image of most chemo drugs. Because it's so targeted at this metabolic difference, asparaginase does not typically cause bone marrow suppression, alopecia, hair loss, or significant nausea, vomiting, or intestinal ulceration. It also doesn't cross the blood-brain barrier.
That sounds great. What's the catch?
The major catch is the risk of severe allergic reactions, including potentially fatal anaphylaxis. Because it's a foreign protein, an enzyme derived from bacteria, the body can mount a strong immune response. Close monitoring during infusion is critical.
Any other significant toxicities?
Yes, it can cause other problems, including coagulation abnormalities leading to either bleeding or clotting, pancreatitis, inflammation of the pancreas, liver dysfunction, kidney injury, and sometimes CNS effects like confusion or depression. So while it avoids the typical chemo side effects, it brings its own set of serious risks.
Okay, let's make a significant shift now. We talked about cytotoxic agents, drugs, designed to directly kill cells, often with broad systemic effects. Now we move to hormonal therapies. This sounds like a different strategy altogether.
It is a fundamentally different approach. Instead of directly poisoning the cell or damaging its DNA, hormonal therapies work by interfering with the hormonal signals that certain cancers use to grow and proliferate.
So these are only useful for specific types of cancer.
Exactly. They're primarily used for hormone-sensitive cancers, cancers whose cells have receptors for hormones like estrogen or testosterone, and rely on those hormones to fuel their growth. The classic examples are estrogen receptor-positive, ER-plus breast cancer, and androgen-dependent prostate cancer.
The goal is to cut off the fuel supply, essentially.
Precisely. Either by blocking the hormone receptors on the cancer cells or by reducing the body's production of the hormone itself. It's a much more targeted strategy than traditional chemo. Hashtag 5.1. Estrogen targeting agents. Breast cancer.
Let's start with breast cancer, specifically ER-positive breast cancer. The first drug mentioned is tamoxifen. It's called an anti-estrogen, but also a SERM.
Right. Tamoxifen is a selective estrogen receptor modulator, or SERM. It's actually a prodrug, meaning it needs to be converted into its active metabolites by enzymes in the liver, particularly CYP-D6.
How does it work on the cancer cells?
In breast tissue, tamoxifen binds to the estrogen receptor on the cancer cells. When it binds, it blocks estrogen itself from binding and activating the receptor. So it prevents estrogen from delivering its growth-promoting signal to the ER-positive cancer cells.
The selective part of SERM is important, though.
Very important. Tamoxifen doesn't act the same way in all tissues. While it blocks estrogen's effects, acts as an antagonist in the breast, it actually mimics some of estrogen's effects, acts as an agonist in other tissues, like the bone and the uterus.
That duality must lead to trade-offs. But first, what's its main role?
Tamoxifen has been a cornerstone of ER plus breast cancer treatment for decades. It's used to treat existing cancer, reduce the risk of recurrence after surgery, and even prevent breast cancer in women at high risk. Studies show it can reduce the risk by around 44% in that group. It's a gold standard.
Okay, now the trade-offs. What are the risks associated with that agonist activity in other tissues?
The biggest concern is its estrogen-like effect on the lining of the uterus, the endometrium. This increases the risk of developing endometrial hyperplasia and, more seriously, endometrial cancer.
So women taking it need monitoring for that.
Yes. Any abnormal vaginal bleeding needs prompt investigation. The other major systemic risk is an increased incidence of blood clots, deep vein thrombosis, DVT, in the legs, and pulmonary embolism, PE, if a clot travels to the lungs. These can be life-threatening. It's also pregnancy risk category D, meaning it can harm a developing fetus.
So a powerful tool, but with significant systemic risks to manage.
Definitely. The benefits usually outweigh the risks for ER plus breast cancer, but careful monitoring and patient education are essential.
Okay, the second major class for ER plus breast cancer is aromatase inhibitors like anastrozole, arimidex. Who are these used for?
This is key. Aromatase inhibitors, AIs, are generally used only in postmenopausal women.
Why only postmenopause?
It's about where estrogen comes from. In premenopausal women, the ovaries are the main estrogen factory. AIs don't stop the ovaries from making estrogen. But after menopause, the ovaries stop, and most estrogen is produced in peripheral tissues, like fat and muscle, through the action of an enzyme called aromatase.
What does aromatase do?
Aromatase converts androgens, male-type hormones produced by the adrenal glands, into estrogen. Aromatase inhibitors block this enzyme.
So in postmenopausal women, AIs cut off the main remaining source of estrogen.
Exactly. They profoundly lower estrogen levels throughout the body, effectively starving the ER-positive breast cancer cells. They are often considered more effective than tamoxifen in the postmenopausal setting.
Since they drastically lower estrogen, what are the main side effects?
The side effects are primarily related to estrogen deprivation. The most common complaint is musculoskeletal pain, joint pain, arthralgia, and muscle pain, myalgia, sometimes quite severe. It can feel like a sudden onset of arthritis.
How is that managed?
Usually with NSAIDs like ibuprofen, patients are encouraged to stay active. We typically only consider stopping the AI if the pain becomes truly debilitating and impacts daily function. The other major concern is accelerated bone loss.
Because estrogen helps maintain bone density.
Right, so depriving the body of estrogen increases the risk of osteopenia, osteoporosis, and fractures.
So bone health management is crucial for women on AIs.
Absolutely paramount. Baseline and follow-up bone density scans, DXA scans, are needed. Patients should be taking adequate calcium and vitamin D, encouraged to do weight-bearing exercise, and often they'll also be prescribed bisphosphonates or other bone-strengthening medications to mitigate the fracture risk.
Do AIs have the same blood clot or uterine cancer risk as tamoxifen?
No, generally not. Because they don't have that estrogenic effect in the uterus or on clotting factors, they are often considered better tolerated in terms of those specific risks, especially since the patients are already postmenopausal. ## 5.2. Androgen targeting agents, prostate cancer.
Okay, let's switch to prostate cancer. Here, the fuel is testosterone and androgen. The goal is to interfere with testosterone's effect on the cancer cells.
Correct. Most prostate cancers rely on androgens for growth, so reducing androgen levels or blocking their action is a primary treatment strategy, often called androgen deprivation therapy, or ADT.
The first approach mentioned is using GnRH agonists like Leuprolide, Lupron. How do these work? It sounds counterintuitive for an agonist to lower hormones.
It is a bit paradoxical. GnRH stands for gonadotropin-releasing hormone, which is normally released by the hypothalamus, and tells the pituitary gland to release LH and FSH, which in turn tell the testes to produce testosterone.
Okay.
Leuprolide is an agonist, meaning it mimics GnRH. When you first give it, it stimulates the pituitary, causing an initial surge in LH, FSH, and consequently testosterone.
A surge. That sounds bad for prostate cancer.
It can be. This is called the tumor flare. For the first week or two, symptoms like bone pain or urinary obstruction can actually get worse due to this temporary testosterone spike.
So what happens after the surge?
With continuous stimulation by the GnRH agonist, the pituitary receptors eventually become desensitized and downregulate. They stop responding. So after the initial flare, LH and FSH levels plummet, and testosterone production by the testes effectively shuts down, dropping to castration levels.
Oh, so it's like chemical castration after the initial flare.
Exactly. The main long-term side effects are those associated with low testosterone. Hot flashes, fatigue, loss of libido, potential bone density loss over time.
Is there a way to avoid that initial tumor flare?
Yes, that's where the GnRH antagonists like daguerreotyx come in.
How are antagonists different?
Daguerreotyx binds directly to the GnRH receptors on the pituitary gland and blocks them immediately. There's no initial stimulation, no surge. It causes a rapid decrease in LH, FSH, and testosterone right from the start.
So no tumor flare.
Correct. That's its main advantage, especially for men who already have significant symptoms like bone pain or risk of spinal cord compression, where a flare could be dangerous. Daguerreotyx is used for palliative treatment of advanced prostate cancer, aiming to quickly reduce symptoms and improve quality of life. It's given as a subcutaneous injection, starting with a larger loading dose, then monthly maintenance doses.
Okay, so we can lower testosterone production. What about blocking the testosterone that's still around? That's where drugs like flutamide come in, an androgen receptor blocker.
Right. Flutamide is an anti-androgen. It works by binding to the androgen receptors on the prostate cancer cells, physically blocking testosterone and its more potent metabolite, DHT, from binding and stimulating cell growth.
The notes say flutamide is indicated only in combination with castration. Why?
Used alone, flutamide isn't very effective because if you only block the receptor, the body often compensates by producing even more testosterone, overcoming the blockade. So it's almost always used together with either surgical castration or chemical castration, a GnRH agonist or antagonist.
What's the purpose of adding it then?
It serves two critical purposes when used with a GnRH agonist like leuprolide. First, it can be started a week or two before the agonist to help prevent or lessen the severity of that initial tumor flare by blocking the effects of the testosterone surge.
Ah, okay. And the second reason?
Even after castration, the adrenal glands still produce small amounts of androgens, and sometimes the prostate cancer cells themselves can make some androgens. Flutamide blocks the action of these remaining androgens, providing a more complete androgen blockade, sometimes called combined androgen blockade, or CAB.
Are there specific risks with flutamide?
Yes, it can cause diarrhea. Patients should also be aware of the possibility of rectal bleeding, potentially seen as black tarry stools, though this is less common. The most serious potential side effect, though rare, is liver toxicity.
Hepatotoxicity, how serious?
It can be fatal in rare cases. Because of this risk, regular monitoring of liver function tests, ALT, AST, is absolutely mandatory, typically every month for the first 4 months of therapy, and periodically thereafter. If liver enzymes rise significantly, the drug must be stopped. #tagoutro.
Wow. That was an incredibly detailed journey through the world of chemotherapy and hormonal therapy, from drugs that cause widespread DNA damage to those that just block a single hormone signal.
It really highlights the complexity, doesn't it? The sources show it boils down to needing incredible precision, constant monitoring, and that strategy of combination therapy.
Yeah, the precision in targeting the cell cycle S phase, M phase, and the combinations designed to hit multiple weaknesses and prevent resistance. That really came through.
And the monitoring. Thinking about cisplatin in the kidneys, cyclophosphamide in the bladder, doxorubicin in the heart, each drug demands specific vigilance.
That paradox you mentioned earlier really sticks with me. The patient's falling blood count being a sign that treatment is actually working, even as it puts them at immense risk. It perfectly captures that intense balancing act.
It really does. It's managing controlled toxicity to achieve a cure or control.
And looking back across everything we covered, you could really see an evolution, can't you?
Right.
From those older, broad cytotoxic agents where the trade-off was huge systemic damage for the chance to kill the cancer,
Right, the alkylating agents, the anthracyclines.
to these newer hormonal agents and targeted therapies that might have fewer global side effects, allowing for maybe a better quality of life during treatment, even if they bring their own specific risks like bone loss or clots.
Absolutely. The field is constantly striving for more effective and less toxic approaches. Which brings us to a final thought to leave our listeners with.
Okay.
We've talked a lot about the known DNA damage caused by older cytotoxic drugs like the alkylating agents and platinums and their link to secondary cancers years later. So the provocative question is, how do we weigh that long-term trade-off? the risk of a secondary disease down the road, versus achieving that crucial initial tumor kill today?
That's a heavy question.
And related to that, as we shift more towards these highly specific pathway inhibitors like the aromatase inhibitors or even newer targeted molecular therapies, how might this change what cancer survivorship even means in the future? Will it become less about managing the long-term collateral damage of cytotoxic therapy and more about managing the chronic inhibition of specific pathways, perhaps with different long-term consequences we don't fully understand yet?
That's fascinating. Shifting the definition of survivorship itself based on the mechanism of the treatment. Something for all of us to think about as these therapies continue to evolve.
Exactly. The landscape is always changing.
Well, thank you for guiding us through that incredibly complex but vital topic, and thank you all for joining us on the Deep Dive. We'll see you next time.